that good? Probably not adequate. Circulation, he's got rapid, thready radial pulse. Okay. He's unconscious, moves all extremities to painful stimuli, and when you expose him, he's lying on the ground next to his bike. So based on your primary survey, what are your main concerns? The bleed, shock, airway, right? We're probably going to have to suction quite a bit, right? And we might have to breathe for him, right? Since he's fast and shallow. Is the patient in shock?
Probably.
Yeah.
Literally.
Yes. So what is the definition of shock?
When your body is inadequately perceived.
The body's trying to decompensate for all of everything that's lacking, the blood pressure, the
Okay.
breathing.
So basically, we can narrow shock down to one word, and that word is hypoperfusion. Right? We're not adequately perfusing. We're not getting adequate oxygenation. Right? And when we don't get adequate oxygenation, our cell's going to start dying. And our body responds to that. How?
By directing blood to the vocal cords.
Okay? So first of all, when we think about the body's going to start to compensate, right? The first thing it's going to do to compensate is
Raise your heart rate.
increase my heart rate, right? And then once my heart rate increases, my respiratory rate's going to increase, right? Because I'm now pumping more blood, I need to get more oxygen attached to that blood. So that's why he was breathing fast and shallow, because he's still trying to compensate, right? So, breathing shallow, his heart rate was fast and thready, okay? Definitely showing us signs of compensated shock right now, but probably is going to not be compensated for too much longer if we keep going the way we're going. Why is it so time sensitive? Why is shock time sensitive?
Tissue starts to die.
Okay, tissue starts to die. Okay. We compensate until we can't compensate, right? So our heart rate speeds up, our respiratory rate speeds up, just to keep us adequately perfusing. Once we no longer can adequately perfuse, we start to decompensate, right? We start to see this go downhill. And when we start to see decompensation, what do we see?
Drop in pressure.
Hmm?
Drop in pressure.
Drop in blood pressure, drop in pulse, drop in respiratory rate, pale, cool, ashen color skin, right? All those things that are going to start to happen. And if we can't help that patient and fix them in decompensated shock, they're going to go into what? Irreversible shock, right? Irreversible shock means that. It doesn't matter what we do once they hit that, they started to have MODS. Do you guys know what MODS is? I'm throwing things out there. Multiple organ dysfunction. So, their kidneys are dying, their liver's dying, their heart's dying, their lungs are dying, their brain is dying, right? So it's just a matter of time before everything shuts down. So multiple organ dysfunction or multiple organ failure is really what kills our patients.
And is that when you'll also start to see the, I can't think of the acronym for it, but the
You can,
Okay.
Yep.
When their blood just stops
Like
clotting?
this.
Yeah.
yeah, I see.
Yeah.
So what's special about oxygen transport in the blood? Well, it can only be transported on what? Hemoglobin. Huh?
Only 4 can be on that one.
4 molecules of oxygen on 1 hemoglobin, right? I'm impressed.
Well, I remember that from last time.
Okay.
That's totally different.
But the thing is, if he's lost 2 liters of blood, he's lost a lot of hemoglobin as well. So now he's not carrying as much oxygen as he used to on a normal basis, right? So we lose those red blood cells, right? Is the loss of red blood cells the only thing that can cause shock? No. Right? There's a lot of different shocks. When I think about trauma, I think about neurogenic shock. Right? When we have an insult to the nervous system, or the spinal cord, or the brain. Right? Neurogenic shock. How do we see that? Right? We don't lose red blood cells. There's no bleeding involved. What happens? Our body loses the ability to keep the tone in our vessels, right? Our blood vessels can dilate and constrict. And when we have an insult to the nervous system, we lose that ability to dilate and constrict. And what happens? We just dilate. Now we need the container, your blood container, really large. And the blood that we have in that container isn't enough for the size of the container then. All right. So as we reassess our patient, bleeding is controlled with manual pressure. The helmet is removed with a trauma chin lift to open the airway. Right? And last week we showed the video on how to take that helmet off. He's got fast breathing with equal chest rise and clear breath sounds. So that's a good thing, right? Clear breath sounds equal. He's got a rapid, thready radial pulse. He's starting to regain consciousness and moving all extremities.
That's true.
Because we cut his clothes off, we then want to cover him to maintain his temperature, right? We don't want him to get cold. Why don't we want him to get cold? What happens when I get cold? I start to shiver, right? And I'm spending a lot of energy trying to warm myself up. If I'm spending that energy warming up, I can't spend that energy trying to fix and repair myself. Right? So, why do we check major bleeding first? Right? We change that to that X, right, instead of ABC.
There's no point oxygenating if there's no blood to circulate that oxygen.
Okay? Exactly, right? So, we fix that bleeding first, then take care of the airway and the breathing. So, how does that direct pressure ideally work? How are we applying that pressure?
With a gloved hand.
Okay, gloved hand, some gauze, right? We're going to put that over. What if the gauze gets soaked by blood? Just add to it, right? Just keep adding to it. Don't change it. Just keep adding to it. Can we release pressure once the bleeding stopped?
No.
No, not in this case, right? We need to keep that pressure on. When would you use a tourniquet?
When the bleeding doesn't stop by pressure.
Okay, when the bleeding doesn't stop with pressure and it's in a extremity, right? Can't put a tourniquet on anything other than the extremities. So, bleeding is still controlled by direct pressure. His airway is patent. He's now breathing 24 times a minute with good chest rise, clear equal blood sound or breath sounds. O2 is 97%. Heart rate's 110 at both the carotid and the radial. His skin is cool. He's now conscious, has a GCS of 15, moves all extremities. He's got some abrasion and bruising noted to the left upper quadrant. Alright, so when we think about our abdomen, right, we divide it down the middle and across, left upper quadrant. What do we have organ-wise in that left upper quadrant?
Stomach.
Okay, lungs up in the chest, right? In the quadrant, we're going to have stomach, spleen, okay? So, I now, because of that bruising, right, around that left upper quadrant, I'm concerned that maybe I have a spleen injury, right? So, how would I know if that spleen is bleeding?
You palpate.
Okay, if you palpate, okay, and it's rigid or distended, then we might have some bleeding through that spleen, right? Other than that, it's just a guess, because we don't have ultrasound or x-ray that we can take and see that the spleen is actually bleeding. Right?
Yeah, you would definitely keep looking at, you know, your blood pressure, your pulse, your respirations. 'Cause those could all-
Exactly, right? And from when you first saw this guy to now, he's changed quite a bit, right? For the better.
Mhm.
How come that never really happens? At least not for me. Right?
We're still looking for the seat collars.
Why is it important to check the airway and the breathing in this patient?
You ain't got a breath, you ain't got a patient.
Okay? And we've got that anterior neck bleed, so we have to really, really monitor that in case we have to suction. Right? What signs of shock were present in the patient?
Cool skin.
Cool skin, weak thready pulse, rapid respiratory rate, shallow. Is there a possibility of internal bleeding still?
Yeah.
Yep. Talked about that. Alright, what is damage control, resuscitation, and trauma? Damage control, huh?
Life threats first.
Life threats first, right? Take care of those life threats, the X, the A, and E, and C, right? That's really how we focus on damage control. We don't want it to get worse. So what happens in the body if we lose blood? Well, we kind of talked about it a little bit, right? We lose the ability for us to carry oxygen in hemoglobin, so we have that less, which means we're going to perfuse less, which means there's a greater chance of shock. Okay? Can our organs work without oxygen? For a very short time, right? And it's, you know, if we're using oxygen and everything's going right, we're using aerobic metabolism, right? To create energy. And when we do that, we need to have a molecule of glucose, water, and oxygen to create that energy. And when I've got those three molecules going into a cell, how much energy can those three things create?
Lots. 34. 34 molecules of ATP.
Okay, depending on what book, 32 to 34, right? Okay, so 32 to 34 molecules of ATP, adenosine triphosphate, which is our body's energy form, right? If I take oxygen away from that, how much energy is created with just glucose and water?
2 to 4.
2 to 4. A big difference. We need that 32 to 34 ATP to live normal. If we're at 2 to 4, we're going to live, but not for very long. And that cell's going to die. Okay? So, it shows how important that oxygen, giving that patient oxygen is, right? Especially when they're in shock. So we talked about treating shock, oxygen administration, keeping them warm so they don't use extra energy, and keeping them flat. Okay? So what organs are going to get damaged first?
Your heart.
Kidneys and liver are your first organs to die. Okay? Then your heart, brain, and lungs, when we're talking about shock. If I just cut off oxygen altogether, then yes, the heart, brain, and lungs are going to die very quickly in 4 to 6 minutes. Kidneys, liver, could be 40 minutes to 50 minutes in those cases. That's why we don't have a lot of donated hearts, donated lungs, because how quickly it will die, and we can't bring it back. All right, we talked about estimating blood supply, right? I just imagine that 2-liter bottle poured out on the floor, and then figure out how much is compared to that. When we look at it, if we lose almost a liter of blood, okay, we're going to start to feel slightly anxious. Our ventilatory rate will be in that 14 to 20. Our pulse will be less than 100 beats a minute. We'll have a normal blood pressure, a normal pulse pressure, normal skin, and we'll still be able to pee, right? So we can lose almost a liter of blood and be fine. And that's good because we lose almost a liter of blood when we donate, right? So that's why they don't take much more than that. Class 2 hemorrhage, all right, we're going to lose 1.5 liters of fluid. We'll be mildly anxious, breathing 20 to 30 times a minute, pulse between 100 and 120. Blood pressure will still be normal. Pulse pressure will be decreased. Do you guys know what pulse pressure is? It's the difference between systolic and diastolic. So if I have 120 over 80, my pulse pressure is 40. Okay? So if that pulse pressure becomes 30 or 20, that's narrow. And that means that, we're decreasing our pulse pressure. Class 3 hemorrhage, we lose 2 liters of blood. We'll be anxious, confused, our respiratory rate 30 to 40 times a minute. Pulse will be 120 to 140 beats a minute. Our blood pressure is going to start to decrease. Our pulse pressure is going to decrease. Our skin is going to become cool and diaphoretic and pale. And we'll still be able to pee, but not much. Class 4 hemorrhage, all right, 2.5 liters of fluid, blood loss. They may be difficult to arouse, respiratory rate greater than 35, a pulse greater than 140. Our blood pressure is going to be decreased, our pulse pressure is going to be decreased, skin is going to be cool, diaphoretic, and pale. And normally we're going to have less than 5 mils of urine output, so very little urine output. So, some special considerations. Athletes. Is an athlete gonna respond different to trauma than Agnes at 80 years old. Why?
Heart's in better shape.
Heart's in better shape. Okay?
More blood, so
They,
they could lose more.
they could lose more blood, right? And they compensate really well because they're in shape. As we get older and we get Agnes, who's 80 years old, she's not going to compensate as well. And we need to remember that, right? If I got an athlete, he can compensate pretty good for a while. But if I have Agnes, I need to worry about her because she's not going to compensate as long. Right? Medications. Anybody here have high blood pressure? Take meds? What meds do we see high blood pressure patients on usually? So diuretics, but usually like a beta blocker, metoprolol, right, or an ACE inhibitor like lisinopril. Those control our heart rate and our ability for our body to respond to shock. So if our patient's taking a beta blocker, their heart can't go up high to compensate, right? If I have a patient that's taking lisinopril, all right, lisinopril keeps my vessels more open and doesn't let them clamp down. So my patient, again, is not going to have that ability to compensate. So meds can play a big role in what our patient's going to look like. Okay? Same thing. If my patient has a pacemaker, is their heart then adequately pumping blood normally anyway? So they're going to have an even more difficult time compensating for any trauma or blood loss. Pediatric patients. When we think about trauma in pediatric patients, it's going to be really opposite of what adults face, right? You know, if I get hit by a motor vehicle in the intersection, what types of injuries am I going to usually sustain?
Lower body, pelvis.
Like femur, pelvis, abdomen, right? And if I see a car coming, what's my instinct? To turn away, right? Okay? If a child sees a car coming, what's their tendency?
Freezing.
Deer in the headlights, right? And so they do this. What are they more susceptible to?
Full body.
Head, chest, neck, right? And with kids, because of that, as an adult, if I get hit, what generally happens? My feet go this way, and my body goes on the hood. If a child gets hit, they tend to go down head first, and then under the vehicle if the vehicle keeps going. So the injuries are going to be totally opposite when you think about the same type of trauma. And that's that difference in pediatrics, right? Pregnancy. How much more blood does a pregnant lady have than normal? Almost double, right? Almost double the blood supply when you're pregnant. So that means that really mom can compensate pretty well for blood loss, but baby can't, right? So we look at mom and she seems to be doing fine. We really have to think about that second patient in the baby, right? Because that baby's probably not doing okay. And then you think about just how that baby displaces everything in the abdomen, right? Especially as they get more pregnant. I felt pregnant. You know, as that baby grows and they push the diaphragm up, can mom breathe as easy? Okay? And so usually she's gonna be breathing faster normally anyway. And now if we add trauma and them having to compensate, they're really gonna be chugging along in breathing, right? Because that diaphragm's pushing up. Think about what the baby's doing as far as the spleen, right? The baby's actually gonna what? Absorb more of that impact than we are. And so we have to worry about those types of things with pregnant patients and trauma. Sometimes I've had pregnant girls in car accidents that are fine, right? But I've never let them not go to the hospital, right? Even if they say, no, I'm fine, I urge them to at least go make sure. At least go get a Doppler, at least, do something so that we know that the baby's okay. So what's the purpose of giving IV fluids, guys? You two over here.
Restore that blood volume to bring blood pressure back up.
Okay, so not blood volume, right? Because we're not adding blood.
Yeah,
We're adding fluid, right?
Yeah.
But to bring that volume up
within the vessels.
within the vessels to increase that blood pressure, right? Okay? Again, we have to think about doing it judiciously, right? We don't want to just hook up a bag, high flow it, and be done. We want to be judicious, maybe only go half ways to wide open, and then really watch that patient, watch the response. Because we don't want to push pots out, right? And we don't want to thin their blood to the point, because, adding fluids is just going to fill the container a little bit. It's not going to help us with oxygen transport. How do you monitor your effectiveness of your fluids? Your pressures, right? Your pressures. Okay? Plain and simple. And I'm not going to talk much about blood and blood products because you guys don't do them, so this is really no sense. But if there's a question on the test, we will do a phone a friend.
1-800-WAYNE. Perfect.
That would cover that, right? There is a drug that we carry. It's called tranexamic acid, TXA for short. TXA will actually increase the clotting factor of the blood and help stop bleeding, whether it's external or internal. It's a great product. It really helps. I don't know if Harvey's carrying it or not. But
Expensive?
it's not expensive. It's not at all. Matter of fact, TXA has been out for 30 or 40 years. But we only started using it for trauma, and they use it in surgery a lot to stop extra bleeds in the surgery.
Does it reverse like if someone's on blood thinners?
It doesn't reverse it, but what it does do is it helps the body to clot itself. Right? TXA actually was designed for females with really heavy flows for their periods, and it helped to stop some of that extra bleeding. And then we just took it and used it for trauma because it worked. So types of shock that we could see. Okay, cardiogenic. What is cardiogenic shock? Heart, right? Our heart's not pumping effectively, and because our heart's not pumping effectively, we're becoming hypoperfused, and that's cardiogenic shock. Distributive shock is like sepsis, anaphylaxis. Those are types of distributive shocks. How do we fix anaphylactic shock? Epinephrine, right? Okay. Is there anything that we're going to do to fix cardiogenic shock in the field? Huh? Don't use a lot of fluids because we'll make it worse, right? Okay. Yeah, so distributive shock is probably one of the only ones that we can really fix and help in the field. Okay. Hypovolemic shock, we can give those a little bit of fluids to fill the container, but ultimately the best choice is to give blood. Right? Neurogenic shock, we talked about that, right? Shock due to the insult to brain, spinal cord, the nervous system, vasodilates, makes the container big, and our pressure drops.
Don and I had a question about neurogenic shock.
Okay?
And just like the treatment in the field for that. Typically treatment is for shock is like keeping the patient warm. Would that be contraindicated in this situation?
No, because remember, they are vasodilating, right? Everything. And so even their capillaries will vasodilate. And so from the site of the injury, so let's say my injury's at T5 or T7, right? Okay, so somewhere in here. From that position down, where we've lost control of our blood vessels, our skin's going to be bright red. Because we've dilated the vessels and the capillaries so much that they're starting to leak, and that blood's actually in that tissue. And that's why we become so red. We won't make it worse because at that point they can't control their temperature. So we want to cover them and keep them warm. Right? Obstructive shock would be things like a pneumothorax, where something's impeding our lungs from expanding, like that pneumothorax, or a cardiac tamponade where we get fluid built up around the heart. Again, not a lot we're going to do in the field. Drive fast, right? Get them to the hospital.
So for cardiogenic shock, you say don't use a lot of fluids, is that because the heart, like what you would see in like a CHF?
Yep.
With fluid back up into the lungs?
Yep, it'll cause congestive heart failure and pulmonary edema, and they're going to start struggling to breathe. So preventing hypothermia is important, right? We talked about keeping them warm. If we become hypothermic, we're going to shiver, we're going to use excess energy that we need to help us combat what we're going through. All right, so we're reassessing our patient. Bleeding still controlled, airways patent. They're now breathing 20 times a minute. Lungs are clear bilaterally. O2 is 97%. Pulse is 105. You have an 18 gauge IV with running TKO. No neurologic deficit, and their body heat is maintained with a blanket and warm environment. Just what we want to do. Secondary survey was completed during transport. They were transported to a level 1 trauma center. Once in the trauma center, patient was found to have a ruptured spleen with internal bleeding, undergoes a surgical splenectomy, and makes a good recovery after 5 days in the hospital. Yay, saved it. Right?
Dang lucky.
So,
And Janelle thought he was dead.
but you notice how everything that we came up with, we saw, right?
By the time we got to him, if this didn't happen at the Senex Junction, by the time we got a crew and got there, he probably would be dead on the highway. How long would he self-sustain that? Like if nobody stopped him?
If nobody stopped him to bleed and he's unconscious, he will bleed out.
Yeah. By
Yep,
the time
he
we
will.
get there, if
But
it's
is
not
that like, is it
right at
5
our
minutes,
corner?
10 minutes?
profuse, anterior deck bleeding. If it's profuse, 2 to 3 minutes.
It takes us probably 5 to get to the bay and get rolling.
So unless somebody stopped at the side of the road
That knew what they were
and
doing.
knew what they were
That
doing,
weren't afraid to do anything.
Right, found the location of the blood,
Right.
found something to block the blood with.
you know,
There's so many steps.
alright.
Not trying to be a Debbie Downer, it's just.
Well, but it's realistic to.
Did you say you're not trying to be a Debbie Downer?
No, but I mean, I just looked at like our time, you know, it's 5 minutes from your house down here to, I mean, 5 is pretty fast on those during the day. And then you've gotta get out to wherever he's at.
I said, well, just come and sit down. She was really scared.
Yeah.
She didn't look like she wanted to trust me. I said, just sit down. I said, just keep still. I said, I told the barmaid, I said, get some ice, put in a couple of eggs, and bring it over here. I just put it on her neck, and just put light pressure right up here.
Alright.
10 minutes, it was done.
Wow.
Jordan,
She was,
wake up!
she was very, she saw it.
Someone put a bag of fluid in my arm. I've been caffeinating all day.
You know how to stop that, right? Alright, we're gonna talk about that secondary survey now, okay? So, we have a 40-year-old male patient who has fallen off a roof. It's Saturday morning, early November. Patient lost his balance and fell approximately 12 feet from the roof.
Been there and done that.
Diabetic.
Been there, done that? Diabetic,
Seizure.
I was gonna say a stroke.
stroke, MI,
Or you just being dumb.
or he slipped, right?
Yeah.
Yeah.
Life tickled